Hello, everybody. Welcome to Angle Rounds for January 2022. Today's presentation will be from our own Dr. Tony Pisani, who's an associate professor in psychiatry and pediatrics. His presentation is entitled Suicide Prevention in Health Systems, Data-Driven Innovation in Workforce Education. We also have a guest who will be introducing him. And I'll say more about that in a minute, but just want to give some housekeeping notes at the beginning here. One is that everybody's microphone and camera will be turned off and remain off during the presentation. Another one is that we hope people have questions at the end. And if you do, please write them in the Q&A area down at the bottom of your screen. Click on that and write in your question. I will read the questions to Dr. Pisani at the end of the presentation. Please don't put questions in the chat box because that's just for comments for the presenter and the interpreters and the panelists here. And finally, it's important that we get feedback, that people fill out the evaluations. There'll be a link to the evaluations on a slide at the end and in the chat box at the very end of the presentation, and then sent out again tomorrow. So for now, I'd like to introduce Christina Mosgraber, who's the Chief Operating Officer of NAMI Rochester, and also has lived experience relative to the presentation we'll be hearing about today. Okay, so Christina, would you like to go ahead and introduce Tony?
Yeah, thanks so much, Steve. Appreciate it. So like Steve said, I'm Christina Mosgraber, Chief Operating Officer at NAMI Rochester, and I have the privilege of leading the lived experience faculty team at Safe Side Prevention. 7 years ago, I almost lost my life to suicide and found myself here in this hospital. And I'm happy to say that I'm alive and thriving today. And now I devote my career to improving the lives and care of people with similar experiences. And for 6 years, I served on the DPAC in the department, which is still very, very close to my heart and actually how I had the privilege of meeting Tony. So I'm pleased to introduce my colleague and friend, Tony Pisani, today. And as many of you know, he is an associate professor of psychiatry and pediatrics. Tony has dedicated his career to preventing suicide. His work on suicide prevention spans from upstream work in schools and communities, applications of technology, clinical interventions, and the work that you'll hear about today about workforce, education, and quality improvement. When I met Tony 4.5 years ago, I was particularly impressed by the fact that no matter what sector he was working in, his work was driven by person-centered care and interventions. Today, Tony will mention the projects that he and I and the Safe Side team are contributing to in Australia and New Zealand. And at Tony's request, I'd like to make 2 acknowledgements that are part of every public presentation that occurs there. First, I would like to acknowledge the traditional owners of the land on which we are meeting today, the Seneca people of Western New York. We honor the elders past, present, and emerging. Secondly, I would like to acknowledge the lived experience of those with suicide concerns and mental illness who are here today. We acknowledge their families and their carers. We acknowledge the clinicians and researchers who have experienced loss and anguish. Your experiences of mental health care systems and services inspire and inform our efforts to build on strengths and address the challenges within the mental health system. Tony?
Thank you so much, Christina. Christina is one of my heroes, and you can see from this picture, if it was in Time magazine, she's pictured there as a hero too. So a big shout out to Caroline Nestro, who first introduced us, and I've learned so much from Christina over the years and continue to. So suicide prevention in health systems involves these 3 core domains: pursuing a culture of safety and prevention, pursuing best practices, policies, and pathways, and workforce education and development, having a really robust approach to developing and caring for people who are doing this, rewarding but hard work. Today, we're going to be focused on this part of this kind of conception, the workforce education and development. And because really it's the people, right? It's the people in any organization that make up the culture that will live out those practices. You can have practices and policies on paper, but it's going to be the people who enact those. And what I'll be sharing today is kind of a learning journey for me that has been kind of trying to follow data and other experiences to figure out how can we have robust, scalable, sustainable, compelling workforce education and suicide prevention. About 2/3 of what I talk about today will be kind of following this data trail that I've been on really for the last 15 years. I'll also share some about a randomized controlled trial that I'm excited about that's about to launch. And finally, I have the goal of inviting people, you, to collaborate. There is a lot of data and opportunity in the things that I'm going to share. And so really looking for people who have ideas, research ideas, clinical ideas to share. So I'll be providing some of those there at the end here. So some acknowledgements. This is like a really full page, and that's because I have a really full life, of people who have been contributing, teaching me, coming alongside me, helping me when I was hurt. So a lot of people to acknowledge and thank along the way. You'll be hearing about some of them in this data journey, but others here on the screen all played a role, as well as others probably who I didn't include on the screen. Also have some disclosures to make. First, that some of this work was funded by AHRQ, a grant that Wendy Cross led and contributed to, and I'll be sharing a little bit from that as well. Also, I'm the founder and owner of SafeSide Prevention, which Christina mentioned before, and SafeSide receives fees to healthcare organizations and government entities here and elsewhere. And the university receives royalties from SafeSide, and so also has a financial interest in some of what I'll be sharing about. There's a conflict of interest plan in place at the university per guidelines. I also received some book royalties from a book that we recently published. And of course, I want to acknowledge George Engel. This is the Engel Research Rounds. And one of the things that George Engel contributed is a view of people that was not reductionistic. He really tried to impress in all the things that he wrote, and from what I understand when he spoke and taught, that things are complicated and we have to have different ways of knowing and listening in order to really help people. And so he was very much committed to science and to kind of following the trails from many different levels in the biopsychosocial model. Finally, I have a promise that I'd like to make, which is this. I have a lot that I wanted to share with you today, and I have a little bit of time that I'll devote at the end, but if I don't, I will answer every question that is asked in the Q&A later in a video. I have a track record for doing this. And so if you take the time to think about and ask a question, I will answer it, even if I don't leave quite enough time at the end to answer all of them here today. Okay, so speaking of that learning journey, that journey for me started a number of years ago with loss. In a clinical service that I was directing here, we lost in a course of only a few months 2 patients to suicide. And that began me trying to figure out how can I first help equip the people around me, myself, and others. And what I realized was that there were 2 things that we needed. One, we needed to be equipped and growing with the best practices in an evolving field. And to that point, I hadn't really followed what was the latest in suicide prevention, and didn't have exactly a way of knowing, taking it in. I was pursuing different kinds of continuing education, but not really, hadn't learned very much about suicide prevention. The second thing that we needed as clinicians was to be supported, connected, and refreshed in this rewarding but very challenging work. And so I went about trying to figure out how could I do that for myself, for other people. And the first, thankfully, because we're here at the University of Rochester, the Center for the Study and Prevention of Suicide was, sort of right down the hall, and I had colleagues who could help point me in the right direction. And the first step in that was suggested by colleagues here, Gates Conwell, Eric Kane, but also Wendy Cross, who's been really important in this journey, and a collaborator that we have from Columbia University, Maddie Gould. We undertook, that's the first paper I published related to suicide prevention, was trying to take stock of what was going on in workshop education at the time. We conducted a systematic search, and then that had, where we looked for articles for training that had targeted a mental health professional, aiming to develop competence in suicide risk assessment and management, and had at least one peer-reviewed article. We found 12 of these and characterized those based on what was in the literature, as well as contacting the developers of each of those, having them complete surveys and interviewing them to really kind of get a sense of what were things like at that time. We characterized, who was doing the training, what was the content of the training, of these different trainings, and what kind of outcome studies. Most of our outcome studies were related to increasing knowledge and confidence, and there were a couple that had addressed patient care outcomes as well, but not many at that time. And so one of the conclusions was that workshops had not yet been demonstrated to improve the clinical care of suicidal patients. So we were wondering, so what would? How could we have education that would get closer and closer to clinical care? And that's kind of continued the journey that many of us in this field are on ever since. My own first response to that was to a training that we developed here called Commitment to Living. Wendy Cross, Ken Connor were very involved in this. And some of you who were here, 10 years ago or so will remember that we actually rolled this training out across our department and then studied it. This training had a couple of unique features, using visual concept mapping based on constructivist learning theory. And this is a kind of concept and schema mapping is a pretty well established in other health sciences education, and focused a lot on teaching through practice and documentation samples. And in fact, this became the first training to show objectively rated skills improving in result of just a brief training. People improved their knowledge and confidence, but we also coded samples that we gave of people writing a risk assessment, and we're actually, with a pretty large effect size, able to show improvements. And that was really the first time we had really seen skills. Now, there still wasn't skills in patient care, but we're trying to move there. And importantly, what we saw from this were similar gains for people with a lot of experience and not very much experience. And that became another theme for me in this kind of following the data journey, was I really wanted, we wanted training that would continue to engage people who have been in the field for a while, refresh them, as well as being something that you could really bring somebody new on with. But there were problems, and they had to do with scale and continuity. Even in, so at the time, Dr. Kane had sort of invited me into a project he was involved with in the Office of Mental Health. And so I was traveling throughout the state doing this workshop and others with the Suicide Prevention Resource Center. But it turns out that you can almost never give enough workshops to get and keep the workforce of mental health, let alone other health professionals, trained. In our own department, it became untenable because so many new people starting all the time. It became untenable to continue this kind of training. And so as a result, for a number of years now, there really has not been a consistent effort around suicide prevention education. So that was kind of discouraging. It was like, okay, we're starting to see this. Maybe there's a place we can develop, but how can we scale this? So that became another kind of theme, like how can we scale and continuity? Because in the Office of Mental Health project, I would go back, I would give a training and then go back a year later. And what I found is in that year in between, people didn't remember anything that had just been said. People were, or sometimes they'd say, Dr. Pisani, I'll never forget what you said when you came here last time. But it'd be something I didn't actually say, or I didn't believe anymore, or had changed. And so there were problems of both scale and continuity. Okay, so here was another model. It was invited by Wendy Cross and Maddie Gould, who I mentioned before, to be part of a project that Maddie led. That was initially SAMHSA funded, then NIMH funded, which was this really interesting project, this kind of time-sensitive research that would be almost impossible to do again, where there was about to be a national rollout of a suicide prevention program. And Maddie managed somehow to get the funding to have this national rollout take place in a randomized fashion so that we could really study the impact of that training. And those of you who know Wendy's work, she's really interested in training science. And so we had a subaward from that grant where we developed observational measures and actually videotaped trainers who had attended a Train the Trainer program. So Train the Trainer, the idea is you have a set of master trainers, maybe 3 or 4 or 5, and then they train whole bunches of other people who we call the second generation trainers. And there was kind of mixed results in this. Some of the outcomes were really good. So callers who had spoke to a trained counselor felt less depressed, suicidal, and overwhelmed in this randomized trial. But unfortunately, the fidelity of those second generation trainers was pretty poor. Or I should say probably varied. There were some people who were really good and probably carried some of those positive results. But a lot of people just, you can understand this is not your job to train. You're training, you learn this thing. They went to a 5-day Train the Trainer in order to deliver a 2-day workshop, but it's really a heavy lift. Wendy also showed in other studies that this model, in one other study with mental health disaster training, that it's also kind of a risky model, in that a lot of times people go to a Train the Trainer, but never actually go on to deliver those training. In another paper in 2017, we actually showed that the competence with which somebody had, of the training that the person had experienced, could actually be traced into observed observations in their crisis calls. So it mattered. And so this is where we saw that fidelity matters for what patients actually experience. And that's why had a pretty profound effect on me, because I was thinking, oh gosh, this would be a way to scale. And it has some positive aspects to it, but there are also challenges. So now, gosh, we had the problems of scale and continuity, and now also fidelity. So this was kind of a concerning state that I was in. This is where my journey took some turns. We had this interesting data, but this is where I started to also work on different parts of the prevention continuum. I won't talk about all of that work here today, but I'm going to talk about something that I learned from that work that later became important in trying to solve this scalability problem in workforce education. And that's the work that I've done with Peter Wyman, my close colleague and mentor, and probably one of the most brilliant scientists I know. Love him. But work we did and are continuing to do with the US Air Force focused training on what we came to call natural organizational units. That is, training people together with the people that they work with. With the aim being not just them, each person individually developing skills, but also to strengthen the group through that process. Now, this is a very different setting. This is a universal intervention, population-oriented intervention in the Air Force, not a clinical training at all. But I was really being absorbed by this and seeing data. And so 2 or 3 papers have now been published. This one is one of the is one of the projects I'm most proud of having been part of, is this randomized trial of this program. But began steeping in that, and these things. So this is part of that data journey where I'm just learning from what we were studying, and it kind of percolating. And so continued along that way, and really hadn't done much since kind of bumping my head against the wall of those scalability scalability and fidelity issues when it came to clinical training, until Wendy Cross came to me thinking about a grant where her main agenda was really to study how would working with simulated patients influence primary care providers' learning. Now, I was trained as a primary care psychologist, and had learned a great deal from Susan McDaniel, Peter LaRue, and others about primary care, and written some papers in that area. But what Wendy was really looking for was a control training. And so we put sort of a scheme together and applied for funding from AHRQ and received that funding. And as a result, developed this online training that was the control group in a study about patient simulation. And here's me standing awkwardly next to a plant on my desk, teaching in this initial online learning. It was me, a talking head with some diagrams, basically bringing together some of that commitment to living work that I described before, plus some of the ways that I had already been teaching it in primary care, and we brought it into these online modules to be the control condition for this study. Well, along the way, we decided, well, let's see how people are responding to this control group, and so we conducted a study and looked at these measures. One was engagement behaviorally. So we were able to see the proportion of these video modules that people watched. We couldn't control. This was the people in this study were residents from pediatrics, med peds, and family medicine, as well as nurse practitioner students. They were given the assignment to view this video material, but we wouldn't control how much they watched of those things. So we could get a measure of how engaging was it to them, given that they could click off at any time. Did people learn? Did they feel more confident afterwards? And did they feel like what I was teaching with that plant next to me was applicable to their work? When it came to engagement, I was really surprised. People watched a lot of what we put out there. There was engagement rates so the play rate over here is how many people started a video. And then the second one is how much, if they started, how much of it did they view? And pretty much across the board, you had like an 80 and 90% of these, when somebody started them, they completed them, and they were interested enough to click on. But I think for me, this engagement rate was the main thing, because it meant once they started, they were pulled in enough to watch almost all of it. And there was kind of music at the end and credits. And so some of that was not material that mattered anyway. And so we had pretty good engagement. So yeah, seemed like it was kind of engaging, this control condition. Did people learn? Yeah, they improved pre-post in knowledge and self-efficacy. So that was really good. When it came to perception of learning transfer, though, this has been one of the strengths of that original commitment to living study, that people really felt like, wow, what I'm learning with this documentation and everything, I can actually use it when I'm done. In this study, not as much. It wasn't terrible, but there were some places where, like, when you're giving people a scale from 1 to 5, you don't want them giving a 3 when it comes to something that you care so much that people learn. And so here we had this was quite a bit below what the original commitment to living on the same items had been. And for me, I felt like, no, this was not really good enough. And actually just last week, another paper was published showing that when people tried to show skills after this, they weren't able to show the full range of skills. Thankfully, people gave us a lot of suggestions, which we really appreciate. And it was pretty obvious what people wanted: scenarios, examples, more concrete examples. We didn't provide enough examples. What about examples? Closer to patients. We want to hear from patients. And so from this, we identified, what would be the next steps? And that would be to have demonstrations, to have the voice of a patient, a person with lived experience, having something that's a more memorable schema, and added opportunities for practice and feedback. And this is where the data journey crossed with this man. I don't know if anybody here knows who this is. A wounded veteran and a really hilarious, caring guy named Johnny Farner Vitelik. And he presented at a faculty meeting. Just as I was digesting these different data, learning these different things, he presented with a plea from the trustees of the university and from UR Ventures. UR Ventures is the arm of the university that tries to help people where there's been discoveries that might be useful out in the community or in healthcare, bring those things out of the university and into regular use. And apparently at that time, there was a really kind of big push to include that. And he came to psychiatry, and with a very passionate plea, he's if you ever meet him, he is a passionate person, really cares about mental health, does a ton of great work with vets. And he said, you guys have got to get your work out there. People need it. I was really touched by this, really moved. And so I was sort of scratching my head like, people are asking about my work. I have been presenting this places elsewhere. But, there's the problems of scale and fidelity. But wait, I've got these sort of ideas about what we might do. But the problems of scale and fidelity. At which point, literally while I was sitting in the faculty meeting, I thought about a study that I'd been part of that Ken Connor led maybe a year or two before that. And this was a small but very meaningful study. Ken led the development for SAMHSA of this TIP 50, which is a treatment intervention protocol for substance use providers. And then participated in a program of developing these video-based modules. But unlike the online learning that I was just describing to you, this was videos that were presented to a group without a trainer there, just there was a suicide prevention coordinator who brought them together and could sort of answer questions. But it really was this this model of video-based group learning, and the sort of conclusion from this paper that Ken led, it was that the positive results, together with the brevity of the training and its ease of implementation, indicate high potential for widespread adoption and importance of further study. And I was like, oh my goodness, maybe this cracks this nut around scalability and fidelity, because everybody was seeing the same thing. They didn't need to have a trained trainer there. And maybe this was something to pursue further. Yay! In the meantime, there had been other interest in this paper that we had written and getting some adoption in a lot of different health systems, including quite a bit in Australia. So that was where I founded SafeSide Prevention and worked with Johnny to license the work that I had done here at the university and try to bring it to have an impact on more people and continue to study it. And so from all of those things, these were sort of like some founding ideas. What we determined on the left here was what was needed for workforce education and suicide prevention was expert production, high fidelity to content, ongoing interaction with experts. Got to have that continuity piece. Group interaction, right? Because of that, those things I was learning about network. And I also reading lots of dissemination and implementation research showing that people don't adopt new practices by themselves. They do it through their networks, through groups. And that this is a critical, almost, truth in scale up dissemination and implementation research that key opinion leaders are important, that networks really matter. So that had to be built in, whatever we were going to do. It had to be sustainable and repeatable, including for new staff, education and refreshers. Remember, we ran into that problem here in the department. It just couldn't do enough workshops, and giving people a role in tailoring this to their own environment. So basically, when I sort of looked back on what we now understood about workforce education, it seemed like expert workshops that we had studied did have, obviously they have high fidelity because this is an expert doing it, good instruction, and you could get some group interaction going. But train the trainer, well, it had some group interaction, but the fidelity was sort of variable. And as I mentioned before, Wendy Cross's 2010 paper on mental health disaster training showing that it might seem like a more sustainable model than it is, because only a small proportion go on to who attend the trainer actually go on to provide that training, sometimes because they just don't get enough opportunity, sometimes because they get promoted and go on to do other things. And then individual online learning, you could get really good fidelity. I mean, you give people, assign them a module, they do the same thing. Well, actually, that's wrong. There shouldn't be an X there for group interaction, because that's one of the things that's missing there. From that is that it is, though, what we could say is that it is sustainable and repeatable, because you can give people the same module every time and they get it, but you don't have that group interaction. And between us, we know that a lot of times if you assign online modules, even something that you care about, it ends up on one corner of the screen and you click through and until there's a quiz question. And most of us got, this far because we know how to answer quiz questions pretty well. And I didn't want suicide prevention training to be that way. And so that's where we came to in-place learning and what we're studying now. In-place learning is online learning, like I described from Ken Connor's project, online learning that you do as a group, specially designed training that's done for a group, followed by opportunities for ongoing engagement in a community of practice, consultation, as well as continual updates and refreshers. So I'll give you a little sense of that, and then I'll talk about the other studies going on about this now, including the randomized trial that I'm eager to share about. So this video guided workshop, here's what it looks like. From that study, and I also came to my own kind of conviction about shared learning with clinicians and people with lived experience together. It actually happened while I was speaking to a group. I was talking, hopefully very articulately about the importance of collaborating with patients and people with lived experience. And I realized I'm standing up here by myself. What am I doing? And so that's when I talked with Caroline Nestro, and she introduced me to Christina. Now we work with other lived experience faculty as well. But so co-teaching with clinical and lived experience better together. Then skill demonstrations, and you might recognize the person on the left there. That's Caroline Silva, who's in our department and did a wonderful job in a skill demonstration with a patient actor, in this case, a veteran. But here's where we took that idea from Ken Connors to the next step, is that periodically, after some teaching and demonstration, turns to the group to discuss, apply, or practice the things that have been shared. And our experience is, and we have some data about this, is that that's really where the money is. People don't really just need more information. What they need is interaction around things that matter with the people that they are working with. And so that's the video guided workshop. That's followed by, I kind of come a long way from the awkward plant next to me. That's followed by a community of practice that involves monthly office hours, as well as a community of practice that is an online discussion forum. And we can provide links if you want to get sort of a glimpse of what that looks like. But this is basically bringing people together to network and share questions and ideas. That happens once a month for people who are engaged in this program. Whoops. Oh, alert. Okay, and that's followed by ongoing opportunities for some individual learning and engagement, knowing that this field is changing all the time. That continuity, issue. So there's been both some qualitative and quantitative data about this approach. The qualitative data was really interesting. This is an unpublished study that I can't share yet, but this is with a qualitative researcher at the Department of Veteran Affairs in Australia. And they conducted interviews with 28 clinicians and peer workers. And there were two themes that came out of that work. The first theme was that as a result of participating in this, this program, people felt a greater sense of what they themed organizational belonging. People felt like they're more a part of their workplace, having experienced this. But the other was they really wanted to see this more integrated into their daily workflows. So there's been other studies, a paper that's under review by Dr. Sarah Donovan, who you saw in that, along with partners at Hillside Family of Agencies, who've been really important partners to us in this work. But next, I'd like to share about a randomized control trial that is about to launch in Australia. So this work with SafeSide and bringing that work out into the community has been across the US, in Australia, a bit in Canada, and also in the UK. And in the Department of Veteran Affairs in Australia has implemented this SafeSide program in all of its centers across the country, and now is planning to extend that into providers that they have who are contracted with them. And I'll describe what I mean in a second. The principal investigator is Jennifer Veek, who is at the DVA in Australia and also at Australia National University, and Phil Batterham, a well-known suicide researcher, also from Australia National University. I'm a co-investigator along with Fiona Shand from the Black Dog Institute, which is a really innovative and amazing research and practice place there. So, oh no, not again. What a bummer. All right. I love seeing Christina. That's not the problem. The problem is, Christina, you are coming into okay. Hey, Lee. Okay, here we are. I think we're going to get there this time. Let me share again. So Open Arms has these 37 centers across the country, and about 400 staff. And that's where they have already deeply embedded SafeSide learning as well as into their workflows. But then also across the country, they have about 1,400 of what they call outreach providers. These are basically independent contractors who agree to see veterans and their families in conjunction with Open Arms. Open Arms is the counseling and clinical service of the Department of Veteran Affairs. So if you've served in the Australian Defence Force for even one day, you and your family can be seen at any of Open Arms centers or by these outreach providers. So here's where the project goes. So they're now getting ready to roll out SafeSide to those outreach providers. And so they're going to do that in a randomized way. So there are about, there's a total of about 1,400. They expect about 1,100 of them to participate in this. And they're going to be, I'll share the measures in a second. These counselors will, are attached, also this design, they're attached to one of those centers. So there's basically 37 of these people in these different clusters. And they're going to randomize the order in which the counselors associated with each center receives the training. So, and matching them by size and region. So in other words, they will generate these random blocks of similarly sized and in the same general region centers, all of the outreach providers that are associated with them across the country. They expect there to be about 1,100 of them, I mentioned, in these 37 centers that will be assigned to either a standard care plus the SafeSide program, or a delayed control intervention, which will begin that 6 months later. During the time when that early training group is being trained, they'll be conducting assessments at baseline and at 3 months and 6 months. And those assessments consist of client record reviews. They expect about 12, what did I say before? About 1,500 to 2,000 of these reviews of people who have screened positive for suicide risk. And what they'll be looking for is, do they find among people who have been trained better attendance? Do they have evidence of connection to supports? This is an important concept that's taught in the program. And the safety plan quality, the completeness and the quality of that work. Now, this is going to be a massive undertaking that they are committed to really see causally, because this is randomization, you can actually see cause. Is the training causing people to have this better quality of care? And then some real interesting stuff here too. Think, okay, yeah, self-report measures. We'll have those confidence measures, perception of learning transfer that we've had before. But we're also adding, thanks to new collaborations with Alicia Bungar from Ohio and Reza Yousefi Nuaz, who's right here in the Department of Public Health, who work on social networks in relation to adoption of evidence-based practice. And so there's these clinicians in both the control and the training group will answer questions about the people who are the staff in those centers, whether they know them, whether they talk to them, and whether they have shared care with them. Okay, so there's kind of like 3 levels: just knowing somebody, talking with them, and actually sharing care with them. And they hypothesize that those providers who have participated in this group experience, have been brought into a community of practice, will have more ties back to the center, which is a really important goal that they have for keeping the quality and continuing to have people be engaged in suicide prevention. So that is going to launch here in June. And so we'll hopefully be able to report results back here. Stay tuned. But it's exciting kind of next step in this kind of data journey as we try to figure out. I'm sure we're going to learn a lot and continue to evolve these programs. Well, I said before that I also wanted to extend an invitation to collaborate. As you can see, there's a lot going on with this work, and I've only mentioned portions of it. We're also involved in state projects, one across the whole state of New South Wales. That's where Sydney is in Australia. All mental health professionals in the public and NGO sector experience this. Involved with the state of Utah, South Carolina, and Georgia has just added this to some of their policy requirements. And another really large project that will soon launch is across the Australian Defence Force. All health and behavioral health personnel, and really excitingly, commanders, people in chaplaincy and welfare officers will be engaged in different versions of SAYSIDE, as well as a kind of training for all defense personnel that will relate to these others. Can't get it too much into this project now, but I'd be happy to come back and talk about that. It's a very wide sweeping project, and we would really value additional collaborators in it. We'll be focusing on leadership and culture, reviewing policies, doing a lot of custom educational program development, addressing postvention and evaluation. But there's also projects closer to home. The University Counseling Services. We have a really wonderful collaboration with Michelle Lawrence and others. I mentioned before, Lee Ashrafian has been an amazing contributor. Ken Connor, the UR Recovery Center of Excellence, where we have developed and are now disseminating a module on suicide prevention for people with opioid use disorder. And the Department of Psychiatry will soon be rolling out, with leadership from Zipporah Rosenberg and others, the program here back at home. There is a lot of opportunities to participate. There is access to different health systems. If you have research or questions, we have, or if you are somebody who has sort of techniques or interventions that are being tested and would want to, or maybe are ready to go to a broader audience, there's opportunities there. And different people have already participated. You'll probably recognize some of these faces in some of the video material. Jess Bathrick, who's a nurse here. Rory Doran, who nailed a beautiful scene about extending a safety plan with a family member. Stella King and Cyrus Salahi. Julie Colvin, who also used to be in leadership here. Mentioned Caroline already. Lee Ashrafian was amazing, and this is part. He participated as part of that opioid module, and same thing with Ken Connor. So there's roles to play if you're interested in demonstrating skills that and having those in front of a lot of people. But also asking questions, because I know that a lot of people in our department have educational innovations and scholarship. And so we really, so I really, value, want to like sort of offer this as a platform for people to collaborate. So please, if you'd like to, be in touch with me. As I said at the beginning, I will, any questions that have come through, I will answer. It looks like there is just one question, so that won't be too much to answer afterwards. But I'll ask that question. It's a question about the Joint Commission regulations and the use of the CSSRS. So I will answer that question by video and send it along to people. And I appreciate you participating here today and attending and kind of hearing about this journey that with data and practice that we're on. So thanks very much. Thanks to Christina, Steve, and all who've hosted us.
All right. Thank you, Tony. Excellent presentation. And I'm glad you're willing to answer questions later. And again, for everybody who participated today, please complete the evaluation. The link to it's in the chat box, and you'll also be getting an email tomorrow about it. So thank you again. Thank you again, Tony, and we'll see you all next month.
Thank you.
Take care.
Bye.